Hello everyone. Welcome to the recall session of the medicine questions asked in the May 2022 INI CET exam. To begin with, let me tell you that in general, majority of the medicine questions of this paper was in the easy to moderate range. Now this is in comparison to a typical INI CET paper where the medicine questions are mostly in the moderate to tough range. So slightly easier set of medicine questions this time. Approximately we had around 40 questions from medicine. So let's start off with the discussion of the questions. So coming to the first question, tongue fasciculations are seen in which of the following conditions? Duchenne muscular dystrophy, myasthenia gravis, Guillain-Barré syndrome and spinal muscular atrophy. So examiner is testing your knowledge of this term tongue fasciculations. First of all, let's quickly have a look at some important points regarding the terminology fasciculations. Okay, fasciculations. So what do you mean by fasciculations? So the term fasciculation refers to a brief muscle twitch. Okay, it refers to a brief muscle twitch, and this brief muscle twitch is produced by spontaneous firing of motor unit. So you have a spontaneous firing of motor unit leading on to a brief muscle twitch, and that is what is called fasciculations. Very importantly, please understand fasciculations are classically associated with anterior horn cell disease. They are characteristically associated with anterior horn cell disease. Okay, very important. So this is very important. Now what happens is, in case of anterior horn cell diseases, you would have a affection of the motor unit, and because of this the motor unit discharges spontaneously leading on to fasciculations. Okay, so this affection of the anterior horn cell, you can also give it another term. It is called denervation. Okay, it is also referred to as denervation. Now when you have a denervation specifically involving the bulbar muscles, you get fasciculations involving the tongue. So tongue fasciculations specifically occur when there is denervation involving the bulbar muscles. Now if you look at the question here, the question says tongue fasciculations are seen in which of the following conditions? And what is common to all the options given? All of them are LMN disorders or lower motor neuron disorders. Out of all these options, there is only one option where the disease process is primarily affecting the anterior horn cell, and that option is spinal muscular atrophy, which you can abbreviate as SMA. Okay. Whereas Duchenne muscular dystrophy, this term is for a disease that is involving the muscle, right? It is a muscle disorder. Whereas myasthenia gravis is a neuromuscular junction disorder. Whereas Guillain-Barré syndrome is a polyradiculoneuropathy. Okay, it is a polyradiculoneuropathy. Okay. So one is affecting muscle, the other is affecting neuromuscular junction, then a polyradiculoneuropathy, and finally the spinal muscular atrophy where the anterior horn cell is being affected. Now at least some of you listening to this video would ask a question. Well, you're talking of fasciculation as some pathologic entity. Even I have some brief twitches. Are these pathologic fasciculations? Don't worry, there is an entity that is known as benign fasciculations, which is again common in the general population. So benign fasciculations are also there. So don't think that fasciculations are always pathological. So pathologic fasciculations mostly occur in the context of weakness and wasting. So majority of the times in pathological states, you will have weakness, wasting and fasciculations, whereas benign fasciculations occur without any weakness and wasting. Okay, that point you have got to know. Just a couple of more points regarding this entity of SMA or spinal muscular atrophy. So this entity is an autosomal recessive condition, okay? And in this entity, there occurs programmed cell death of the anterior horn cells. Since it is a hereditary condition and since it affects the anterior horn cell, you can also refer them by another name, that is hereditary neuronopathies. Okay, what is it? Hereditary neuronopathies. Okay, neuronopathies, not neuropathies, neuronopathies, as it involves the anterior horn cell. And I have taught you in my lectures that the SMA is classified into various types based on the age of onset and the severity. You have the infantile form, you have the intermediate form, you have the juvenile form and the adult onset form. I'm sure in pediatrics you would have learned about the infantile form of SMA, which is the Wernicke-Hoffmann disease. Sometimes can be asked as a pediatric question. So in all these SMAs, majority of cases, what is the gene mutation that occurs? It is an SMN1 gene mutation. Okay, SMN1 gene mutation. All right. And the end result in case of SMA is hypotonia and weakness involving the limb and truncal musculature as well as bulbar dysfunction. Okay, very important. So this question, it's an easy one. You just have got to identify in which disorder the anterior horn cell is affected. Answer is SMA. All right, let's go to the next question. So next question is again a cardiology question, and any INI CET exam would have at least one question on cardiac arrhythmias, and this time was no exception. So the question was regarding a 52-year-old diabetic male presented with palpitations and chest discomfort. The blood pressure was 128/70 millimeter mercury. ECG is shown. Which of the following is the initial management? So just have a look at the ECG. Is it primary PCI, adenosine, DC cardioversion or amiodarone infusion? What do you think is the answer? Let's have a close look at the ECG of this patient. You look at the ECG of the patient. When you analyze the ECG, something that is very striking on first look is the heart rate, right? So obviously when you look at the heart rate, you can see that you have 1.5 large boxes, okay, between the consecutive R waves. So RR interval is around 1.5 large squares. So heart rate is 300 divided by 1.5, which is 200 per minute. So the heart rate in this condition is 200 per minute. So you're talking of a tachyarrhythmia. And this is not just any tachyarrhythmia, this is a regular tachyarrhythmia. Okay, there is no irregularity here. And I've always taught you in the basic approach to tachyarrhythmias, once you have understood, okay, this is a tachyarrhythmia, next thing you have got to do is to look at which one? The QRS complex. How is that going to help you? Because if the QRS is normal, or you can say a narrow QRS, you can say that this is a supraventricular arrhythmia, whereas a wide QRS will tell you that this is a ventricular arrhythmia, right? So this one, again, obviously look at the QRS here, okay? Look at the QRS here, you can clearly understand, okay? So this is a normal size QRS complex or a narrow QRS complex. Now the next step in the analysis is you have got to look at the P wave. So again here the P waves are absent. You are not able to demonstrate any definite P waves. Okay. And so there is absent P waves. So you're thinking of a narrow, complex, regular tachyarrhythmia with absent P waves. And so in that scenario, what is the arrhythmia that comes to your mind? It is going to be a paroxysmal supraventricular tachycardia, okay, PSVT, okay. And in addition to that, if you look at the ECG, another finding that you can notice is the presence of ST depression, okay. Similar ECG actually came for your exam also. So majority of the leads you had ST depression, except for the lead AVR you had ST elevation, okay. So that is the other finding you had in the ECG, okay. All right, now this is a flow chart which I commonly teach the students in my lectures about the approach to tachyarrhythmias, looking at the QRS, whether it is normal or wide. This is the approach to tachyarrhythmias, okay, tachyarrhythmias, approach to tachyarrhythmias. And in this case, QRS is normal. Next thing you have got to look is the P wave, whether it is present or absent. If it is present, you have got to see whether each P is followed by QRS, yes or no. And if it is yes, is the P normal or abnormal? But here you can see that the P wave is absent and the patient is having a regular heart rate, which is above 150. And in this flow chart, this is PSVT. I have taught you in my lectures. So this one is a straightforward one of a paroxysmal supraventricular tachycardia. Now students, always you should have a good approach to tachyarrhythmias because that will help you solve questions quickly. Now at least some students had a doubt in this ECG that some students actually asked me, sir, in addition to the PSVT, are you not seeing a global ST depression and an AVR ST elevation? So will that by any chance change the answer? Because management of PSVT is a common expected question. Now let me tell you some basic facts. See, a global ST depression with a ST elevation in the AVR, okay, which means most of the leads ST depression, AVR alone ST elevation. This is an indication of subendocardial ischemia, which occurs because of an oxygen supply-demand mismatch. The lead AVR is actually electrically opposite to the left-sided leads like 1, 2, AVL and V4 to V6. So in case of a subendocardial ischemia, the ST elevation that occurs in the AVR is simply a reciprocal change to the ST depression in the other leads, okay. Now what happens is that, see, if you have isolated global ST depression and AVR ST elevation, you can think of certain etiologies because global ST depression plus AVR ST elevation occurs in certain scenarios. So like one is LMCA stenosis, okay, LMCA stenosis, which stands for the left main coronary artery stenosis, or a proximal LAD stenosis. Proximal LAD stenosis, LAD is the left anterior descending, or a severe triple vessel disease, okay, a severe triple vessel disease, okay, severe triple vessel disease. So these are the conditions that you have got to keep in mind when there is an isolated global ST depression and AVR ST elevation. But remember, when it occurs in the setting of a tachyarrhythmia, the scenario is slightly different because a tachyarrhythmia like PSVT per se, heart is actually beating at a very high rate. So this tachycardia itself can cause a subendocardial ischemia, and which can cause a global ST depression and AVR ST elevation. It might not be seen in all cases, but the point I want to convey to you is that this ECG finding of the global ST depression that you see and the AVR ST elevation does not take you away from the diagnosis of PSVT, okay. So we have got the diagnosis as a paroxysmal supraventricular tachyarrhythmia, and what is the initial management? Now this is also a very commonly expected question, and I've always told you, when you get such a question on a tachyarrhythmia management, always look whether the patient is hemodynamically stable or unstable. So if you look at the question, that itself says that the blood pressure is 128/70 millimeter mercury, which tells you that the patient is hemodynamically stable. Okay, patient is hemodynamically stable. So when you have a hemodynamically stable PSVT, what is the usual management? If the patient is stable, the first thing you have got to do is that you have got to administer vagal maneuvers like carotid sinus massage. Okay, so vagal maneuver. So by the time the nursing staff takes the adenosine, you can administer vagal maneuver. So sometimes the vagal maneuver or the carotid sinus massage per se aborts the tachyarrhythmia. However, if it does not work, if it is not working, you can go for IV adenosine as the next step. IV adenosine as the next step. And still, if it's not effective, the next step will be IV verapamil or an IV beta blocker. Okay, that is going to be the next step. Okay, so hemodynamically stable PSVT is given in the question. You do not have vagal maneuver in the option, so definitely the answer is going to be adenosine. Okay, IV adenosine. What about option C, DC cardioversion? Remember, had the patient been hemodynamically unstable, in that case you will have requirement of a cardioversion. Okay, but in not this case. And what is the difference between a cardioversion and defibrillation? Remember, in cardioversion, you are delivering the energy synchronized to the QRS complex. That is, the shock is given at the peak of the R wave. Whereas in case of defibrillation, it is a non-synchronized delivery of shock during the cardiac cycle. So the defibrillation is given in case of say cardiac arrest with a shockable rhythm. What is the shockable rhythm? Like a pulseless VT or a VF, that is when you give defibrillation. Otherwise, in these arrhythmias like PSVT, you will give the patient DC cardioversion. That is when the patient is having either features of hemodynamic instability, or if all these medications, you have tried all these medications and in spite of that the arrhythmia is refractory, even then you can go for cardioversion. But here in this question, it is a straightforward one. The answer is going to be adenosine. Okay, all right. So let's go to the next question. Next question, again a relatively simple one. A 10-year-old boy presents with fatigue and joint pains. The following skin lesions were observed. What is the most likely diagnosis? So they have shown the image of the hand, the dorsal aspect, and you can see there are skin lesions which are erythematous lesions, especially in the region of the knuckles, yes, the metatarsophalangeal joint, and also in the region of interphalangeal joints you are seeing these skin lesions. So the options are rheumatoid, osteoarthritis, juvenile dermatomyositis and sclerodactyly. Well, if you just have common sense, you see you are dealing with a 10-year-old boy, so that almost excludes the possibility of rheumatoid and osteoarthritis and even sclerodactyly as well. Okay. So dermatomyositis, the entity can occur in adults, but the entity of juvenile dermatomyositis can occur in the juvenile age group. So the juvenile dermatomyositis is often associated with certain non-specific features like fatigue, malaise, some sort of muscle weakness, rash. All these features can be there. Along with that, that is the like in question they have given about fatigue and joint pains, which is mostly vague symptoms, but it can go on to a florid muscle weakness also, where the patient is having significant proximal muscle weakness. But always remember, the entity of dermatomyositis should be suspected when you have a musculoskeletal involvement associated with certain characteristic skin lesions, because the skin lesions are very pathognomonic of dermatomyositis. The term itself is dermato, so it has got to do something with the skin, and myositis, muscle also. So remember the cutaneous signs of dermatomyositis. either can precede the muscle involvement, or sometimes can occur even after the muscle involvement also. Rare cases are there where you can have say a skin manifestation without muscle involvement, which you call it as the amyopathic dermatomyositis without muscle involvement. Okay, amyopathic dermatomyositis is also another entity. Okay, so there are numerous named cutaneous findings in case of the dermatomyositis, very similar to the adult dermatomyositis also. You can have heliotrope rash, which are the purple red discoloration around the eyes, especially the region of eyelids, which is often associated with a periorbital edema. So sometimes you might get a question on heliotrope rash also. So one skin lesion is a heliotrope rash. Okay, and then you can have say other named signs like V sign, shawl sign, all I have taught you. Okay, V sign, shawl sign. There is also Holster sign. Okay, Holster sign. Holster sign is the lateral aspect of the thighs, okay, having the violaceous or erythematous scaly plaques. That is the Holster sign, which you might not see in some of your books, but it is given in the majority of the standard rheumatology books. Now, in addition to all this pertinent to our question, always remember in the region of the dorsal aspect of the metatarsophalangeal joint and the interphalangeal joint, you have violaceous or erythematous papules, and which are known as the Gottran's papules. So in your question, you are seeing Gottran's papules. Okay, in the question you are seeing Gottran's papules. So these Gottran's papules are pathognomonic of dermatomyositis, and just like you have this term Gottran's papule, there is also another term that is Gottran's sign. Okay, so what is this Gottran's sign? How is it different from Gottran's papule? Gottran's sign refers to the violaceous papules and plaques that you see on the elbows and knees. On the elbows and knees, you can see certain violaceous papules and plaques. That is the Gottran's sign. So what is the other cutaneous involvement? Sometimes you can have calcinosis and cutaneous ulceration. Okay, so this calcinosis and cutaneous ulceration, remember, is more common in the juvenile dermatomyositis than the adult dermatomyositis. So with a 10-year-old boy with fatigue, joint pain, some non-specific symptom, but the characteristic Gottran's papule, the answer is going to be juvenile dermatomyositis. Very simple. The next question, spinal cord affection can cause all the following except crossed hemiplegia, bladder involvement, sensory loss at a particular level, both UMN and LMN findings. Well, see, if you look at the options, this is actually a very simple one, because often when I have taught you about the stroke localization in the video modules, I have used this term crossed hemiplegia many a times. So what is this term crossed hemiplegia? Remember, crossed syndromes of the brainstem. So I've taught you numerous syndromes, namely the Weber syndrome, Benedict syndrome, so many cross syndromes. So crossed syndromes of the brainstem means, what did I say? Brainstem, cross syndromes of brainstem, which again tells you that the involvement is in the brainstem and not spinal cord. So crossed syndromes means you are having a cranial nerve dysfunction ipsilateral to the lesion and a long tract, which may be a motor or a sensory tract dysfunction contralaterally. For example, if you think of the Weber syndrome, you remember me teaching you the Weber syndrome? So Weber syndrome, here you will have an ipsilateral third nerve involvement. Okay, so ipsilateral third involvement plus a contralateral hemiplegia is a Weber syndrome, which is called a crossed hemiplegia, Whereas the other options, bladder involvement, yes, can occur in spinal cord disorders. The sensory loss at a particular level can occur in spinal cord disorders, especially in compressive myelopathy. Below the level of lesion, you can have complete loss of sensations. and both UMN and LMN findings. Now this is also very interesting. See, I'm just giving you a scenario, okay? Suppose if I have a compressive cervical myelopathy and this is pressing on the C6 segment, okay? It is pressing on the C6 segment. So when the compression occurs at the C6 segment, obviously the anterior horn cells of that segment will be affected, and corresponding to the C6 segment, you are likely to have LMN findings. LMN findings. Whereas below the level of lesion, below C6, all the findings will be UMN, like you get a brisk knee jerk, brisk ankle jerk, extensor plantar. So remember, you can get UMN and LMN findings in spinal cord affection as well. Whereas crossed hemiplegia is suggestive of a brainstem affection. Okay, crossed hemiplegia is suggestive of a brainstem affection. Okay, all right, so that is also clear. Let's move to the next question. So next question is again a question pertaining to spinal cord. So you had two questions from this spinal cord segment. Okay, so all are true regarding Brown-Sequard syndrome. Okay, all are true regarding Brown-Sequard syndrome, except one is complete transection of spinal cord, contralateral loss of pain and temperature, no motor deficit, ipsilateral loss of proprioception. So you had various combinations, like option A was 1 and 3, 1, 2 and 3, 1, 3 and 4, 2 and 3. So these were the options. Now always remember, in any exam, Neet PG or INI CET, majority of the times, okay, 3 out of 4, I can say 75% you are likely to get a question based on one of the spinal cord syndromes. So you're likely to get it, okay. So you take 4 INI CET papers, maybe at least 3 you would get a question related to the spinal cord syndromes. And I'm just showing you the pictures, the representative pictures of the various spinal cord syndromes. So you have the complete cord transection, Brown-Sequard, syringomyelia, subacute combined degeneration, tabes dorsalis, anterior horn cell syndrome. You have the ALS, amyotrophic lateral sclerosis, anterior spinal artery occlusion. All these are very important. Okay, so either they may ask about Brown-Sequard or a syringomyelia or a subacute combined degeneration. So this time in INI CET, the question came about Brown-Sequard syndrome, a very simple one. See, whenever you have a Brown-Sequard syndrome, this is a hemisection of the spinal cord. So the first option, you see one is complete transection of spinal cord, which is wrong. So you are asked to choose all except. So this is going to be one of the options you are going to pick. Okay. So it is not complete transection, it is a hemisection of the spinal cord. And this occurs with conditions like trauma. Previously, it was thought, okay, trauma is one of the most common cause, but actually in routine practice, we commonly encounter this more with extramedullary tumor compression than with trauma, this Brown-Sequard pattern. And the neurologic deficit that occurs in Brown-Sequard syndrome is an ipsilateral weakness, okay, is an ipsilateral weakness. And this ipsilateral weakness is because of the corticospinal tract involvement, and there is also an ipsilateral loss of the joint position and vibration. Okay, ipsilateral loss of the joint position and vibration, and this is because of the affection of the posterior column. Whereas you will have a contralateral loss, very important, contralateral loss of pain and temperature. Okay, contralateral loss of pain and temperature. Okay, so this option, contralateral loss of pain and temperature, yes, it occurs, so you cannot choose that. Ipsilateral loss of proprioception, no motor deficit is a false statement, so that also you have got to choose, because obviously there is an ipsilateral weakness. So this is what actually happens. But always remember, another point that I've always stressed in my lectures is that the contralateral loss of pain and temperature occurs 1 or 2 levels below the lesion. I've explained to you with the help of a figure in the lectures. And also, in addition to all these findings, Though it is not asked in the question, let me tell you, maybe at the level of lesion, you can have segmental signs corresponding to the level. Like you may have radicular pain, muscle atrophy, or a loss of deep tendon reflexes. These are all element features. Remember I told you, spinal cord involvement, you can have element sign or at the level of lesion. Okay, so that also is possible. So for this, what is your best pick? It is going to be option 1 and 3, which are wrong statements. Okay, which are wrong statements. Moving to the next question. Which of the following is not an immune checkpoint inhibitor? Very, very important. It was an expected question also, immune checkpoint inhibitors. Pembrolizumab, nivolumab, cetuximab, avelumab. Well, here you have got to understand a few concepts. Okay, one is what is meant by this checkpoint inhibitors. What is meant by this checkpoint inhibitor? That is what you have got to understand. So, to understand what are checkpoint inhibitors, you have got to know what are checkpoint proteins. Okay, checkpoint proteins. Now, see, you've got the T cells, right? You've got the T cells. Now, these T cells have certain proteins that turn them on. Okay, that turn on an immune response. Okay, because T cells can turn on an immune response, and they have certain proteins that can turn off the immune response. Okay, both type of proteins are there. The later proteins that actually turn off the immune response are called checkpoint proteins. Okay, checkpoint proteins. So what do? They turn off the immune response. So there are numerous studied checkpoint proteins. Numerous ones are there. So in the context of cancer immunotherapy, this is very, very important. So one of this is a CTLA4. Then you have a PD1. So lot of checkpoint proteins are there. Even you have the PDL1 also. So lot of checkpoint proteins are there. And these inhibitory molecules or checkpoint proteins are highly expressed on the anti-tumor T cells. Okay, so checkpoint inhibitors, what did I say? Checkpoint inhibitors, they are a type of immunotherapy. Okay, they are a type of immunotherapy. Okay, so these drugs will block the checkpoint proteins. Okay, these drugs will block the checkpoint proteins. Checkpoint inhibitors will block the checkpoint proteins, and they are used in cancer immunotherapy in the part of the treatment of malignancies like melanoma, skin cancer, lung cancer, such malignancies. So what they actually do is that they stop the proteins on the cancer cells from pushing the stop button. Okay, so when that is done, this turns the immune system back on. The immune system is back on, and the T cells are able to find and attack the cancer cells. Okay, otherwise, because of virtue of the checkpoint proteins, the T cells were unable to attack the cancer cells. But with the help of checkpoint inhibitors, the T cells are able to find and attack the cancer cells. Okay, very important. So talking of the options that you have in question, well, option A, B and D, these three options, they are actually checkpoint inhibitors. The question is asking which of the following is not a immune checkpoint inhibitor. The first one is immune checkpoint inhibitor against PDL1. Okay, that is pembrolizumab. Whereas nivolumab is against PD1 receptor. Okay. Whereas the option D or avelumab is again against PDL1. Okay. Whereas cetuximab is nothing but a EGFR, epidermal growth factor receptor. It is an EGFR inhibitor. Okay, it is a EGFR inhibitor. So options A, B and D are immune checkpoint inhibitors, whereas the cetuximab is not one. Now let me just show you one figure. This is taken from Harrison. This is from the 21st edition of Harrison. Okay, Harrison 21st edition. So you see, this is a flowchart on the immunologic treatment options that you have for cancer. And you see at one side you have the immunoregulatory cell targeting antibodies, where you have all these antibodies like atezolizumab, avelumab, cemiplimab, durvalumab, ipilimumab, nivolumab, and pembrolizumab. So you have got all these tongue twister immune checkpoint inhibitors there. Very important. Okay, expected question. So the answer is very obvious. Okay, so at least the ones which I have just told you, please remember. And even in Harrison also they have given it as targeting which one, PD1 or PDL1 or CTLA4, they have given it. Okay, all right, so I hope that is also clear. Coming to the next question, let me tell you, you cannot get a even simpler question. So this question is regarding a 45-year-old female presenting to the physician with easy fatigability and dyspnea on exertion. So on examination, pallor was present. Hemoglobin was 6 gram per deciliter. What is the most likely peripheral smear findings? See, after the exam, many students messaged me. At least some of you got confused that will they ask such a very simple question in INICT, or is it the answer different? So at least a couple of you have made this mistake of overthinking. But remember, this is a very simple, straightforward, very simple question. See, the patient is having anemia. A 45-year-old female is having anemia. And in a 45-year-old female with anemia, what is the most common peripheral smear finding? So just always think of the most common anemia worldwide. What is the most common anemia worldwide? It is iron deficiency anemia. Okay, so iron deficiency anemia is the most common anemia worldwide. And you know that this iron deficiency anemia is grouped under the entity of hypoproliferative anemias. Hypoproliferative anemias. Yes. So the most common among the hypoproliferative anemia is the iron deficiency anemia. What is the second common anemia that is grouped under the hypoproliferative anemia? It is the anemia of inflammation, the acute and chronic inflammation. Okay, so that is the second one in the group. So iron deficiency anemia, like any other anemia, would present with features of fatigue, malaise, headache. In addition to that, you may have certain other features like say a glossitis, stomatitis, chelosis, which refers to fissures at the corners of the mouth, and a very important nail finding, that is koilonychia, which is the spooning of the fingernails. So this is how it actually presents. Now, if somebody asks you what is the peripheral smear finding you expect in iron deficiency anemia, well, you can expect number one, a microcytic hypochromic blood picture. Can you have poikilocytosis? Yes, you can have poikilocytosis in the form of, say, cigar-shaped or pencil-shaped cells. Cigar or pencil-shaped cells may be there. You can have poikilocytosis. You can also have target cells. Now you might ask me, sir, you're saying that in iron deficiency anemia, you can have a microcytic hypochromic picture. Microcytic hypochromic. You can have poikilocytosis in the form of pencil-shaped or coin-shaped or cigar-shaped cells. You can have target cells. Does that mean A, C, and D have equal probability of becoming the answer? No, because see, they have clearly asked what is the most likely peripheral smear finding. So in iron deficiency anemia, what is the most common peripheral smear finding? It has got to be microcytic hypochromic blood picture, though you may get target cells. But target cells, are they specific to iron deficiency? No. So poikilocytosis, are they specific to iron deficiency? No. So the best answer will definitely be a microcytic hypochromic blood picture. So what are you seeing on picture here? This is a peripheral smear of iron deficiency anemia. Okay, peripheral smear of iron deficiency anemia. Yes, you can see marked hypochromia here. Yes. In contrast, you are seeing some normal RBCs also. Okay, let me just put in a different thing. Okay, you are seeing some normal RBCs also, but again, obviously you are seeing microcytic hypochromic blood picture. So iron deficiency can occur because of numerous causes. Causes of iron deficiency like increased demand for iron, increased iron loss or decreased iron intake or absorption. There are numerous causes, but remember this is a common anemia. And for this question, you have got to go for that answer. Okay. So I hope that is very clear. Let's go to the next question. So this time there were two questions from the topic of hypoproliferative anemias. The second question asked about which is true about anemia of chronic disease. Low hepcidin levels, serum ferritin low, TIBC decreased, iron stores depleted. Well, talking of the anemia of chronic disease, there are some very important points you should know. See, you know that anemia of chronic disease is caused by the inflammatory cytokines, and the inflammatory cytokines, what it does is it increases hepcidin levels. Okay, so it will result in anemia of chronic disease. So anemia of chronic disease, one thing you have got to know is that there occurs increased hepcidin. Okay, increased hepcidin levels. So because the hepcidin levels are increased, this will sequester iron in the macrophages of the reticuloendothelial system, because of which it is not available for the RBC synthesis. The iron actually gets trapped. And anemia of chronic disease can occur as a part of various other conditions. Various conditions like chronic microbial infections. Okay, chronic microbial infections can result in anemia of chronic disease. It can result as a sequelae of chronic immune disorders like rheumatoid arthritis. Okay, chronic immune disorders. It also can be a part of various neoplasms like a CA lung or a CA breast or a Hodgkin's lymphoma. So it can be associated with various conditions. Now, what are the iron studies in anemia of chronic disease? Again, very important. So number one, you will have normal or increased iron stores. Normal or increased iron stores. What about the serum ferritin? There is increase in the serum ferritin. There is increase in the serum ferritin. What about the serum iron? There is low serum iron. There is low serum iron. What about the level of TIBC? The level of TIBC is decreased. Okay, this you have got to know very well. And what about the transferrin saturation? Well, in anemia of chronic disease, you will have a normal or reduced transferrin saturation. Normal or reduced transferrin saturation. Most of the times it will fall in the range of 15 to 20 percentage. Okay, 15 to 20 percentage. And also know that in case of the anemia of chronic disease, you can have a increased red cell protoporphyrin. Increased red cell protoporphyrin. Okay, increased red cell protoporphyrin. And this occurs in the setting of a hypoproliferative marrow, which is why this is grouped under hypoproliferative anemias. Okay, so please always keep in mind this one. Okay, all right. So coming to the options, which is true regarding the anemia of chronic disease. Low hepcidin levels, it is a false statement. What about the serum ferritin? It is not low, it is increased. TIBC decreased is a true statement. Iron stores depleted is false. There are enough iron stores. This is again in contrast to the iron deficiency anemia. Here there are adequate iron stores. The problem is with mobilization. So this is also not going to be the answer. Answer is going to be TIBC is decreased. And always remember this table, which I have always taught you on the various parameters differentiating iron deficiency, anemia of chronic disease, thalassemia and sideroblastic anemia. In most of my lectures, I tell you there is often high probability question from iron deficiency anemia and anemia of chronic disease, thalassemia and sideroblastic anemia. This time two questions came. One is from iron deficiency, other is from anemia of chronic disease. Okay, all right. Coming to the next question, all of the following are used in the management of sickle cell anemia except. So another question from hematology, hydroxyurea, bebtelovimab, L-glutamine and voxelotor. So in this question, first of all, let's take hydroxyurea. Okay, see, hydroxyurea is definitely used in the management of sickle cell. So definitely it's not going to be the answer. So hydroxyurea in fact is the standard of care of patients with sickle cell anemia. And how does hydroxyurea act is by causing high levels of HbF. Okay, so it increases the fetal hemoglobin. So there is high levels of HbF, and when there is a high level of HbF, it actually protects from the polymerization of HbS. So protection from HbS polymerization is there, and this in fact forms the cornerstone of management of sickle cell anemia by increasing the HbF levels. Okay, let's go to the option C, L-glutamine. So L-glutamine is also used in case of sickle cell anemia. So how does it act in sickle cell anemia? It reduces the oxidative stress in the sickled erythrocytes. How exactly does it reduce the oxidative stress? We are not very sure. Okay, it's different hypotheses as there, but basically we know it reduces the oxidative stress. So this one is also used in the management of sickle cell anemia, reduces oxidative stress. Okay, reduces. Now coming to the next option, voxelotor. So voxelotor is also used in the management of sickle cell anemia. So how it does is that this drug will increase the affinity of hemoglobin molecule for oxygen. Okay, so it increases affinity of hemoglobin molecule for oxygen. So that is what voxelotor does. Okay, and there is one more drug that is useful in the management of sickle cell anemia, which you may get as a question, which is the crisanlizumab. Okay, what is it? It is crisanlizumab. Okay, crisanlizumab. This is mentioned in Harrison also. You have got to know, which is a p-selectin blocking monoclonal antibody. P-selectin blocking monoclonal antibody. Okay. Coming to the next question. The next question is again a hematology based one. In India, pre-transfusion screening is not recommended for HIV, hepatitis B, malaria, dengue. So if you want to donate blood to another person, there are certain infections which definitely has to be screened. And what are the mandatory infections that has to be screened? Number one, you have got HIV. Then you have got hepatitis B, hepatitis C, syphilis, and malaria. Okay, and in certain countries where Chagas disease is there, you have got to screen for Chagas as well. But these are the infections which has to be mandatory screened. So the answer here will be dengue. Okay, the other ones it is definitely recommended. Dengue not recommended. Okay, all right. Coming to the next question. ACTH is the drug of choice for seizures associated with tuberous sclerosis, West syndrome, JME and Rolandic epilepsy. This is something which I have taught you multiple times in the epilepsy chapter. Well, the answer for this is the West syndrome. So West syndrome, what is West syndrome? This is basically an epileptic encephalopathy. So this is a syndrome which has an age of onset between 3 to 7 months of age. Okay, 3 to 7 months of age. And this is characterized by the clinical triad of epileptic spasms. Very important. Clinical triad, one is that of epileptic spasms, which can either be flexor spasms or extensor spasms, mostly flexor spasms. Then you can have a deterioration of psychomotor development, that is the second part of the triad, deterioration of psychomotor development, deterioration of psychomotor development. And third one is the characteristic EEG pattern, which is again important. What is the characteristic EEG pattern? It is hips arrhythmia. Okay, it is the hips arrhythmia pattern. So this is the classical triad of West syndrome. Now, West syndrome, the treatment of the infantile spasms or epileptic spasms associated with West syndrome is slightly peculiar to the conventional treatment of seizures, because in this entity steroids have a definite role. Okay, so steroids like ACTH, especially ACTH, and even prednisone also has benefit in the treatment of West syndrome. Okay, so this is again very unique type of epileptic encephalopathy. Okay, and this point also has been asked previously in certain exams, the hips arrhythmia pattern on EEG. What is this hips arrhythmia pattern? Well, EEG in case of West syndrome will have a high voltage disorganized EEG activity, and in between you can see some slow waves, some spikes, some sharp waves. So you have a very dirty looking EEG. What did I say? Dirty looking EEG. That is what is commonly referred for the hips arrhythmia pattern, a very shabby, dirty looking EEG with so much of small waves, high voltage waves, spikes, sharp wave. That is what you get in case of hips arrhythmia. In between you can have periods of attenuation as well. Okay, so for this question the answer is going to be West syndrome. Okay, moving to the next question, which is an X-linked dominant disorder? Rett syndrome, ornithine transcarbamylase deficiency, Duchenne muscular dystrophy, and spinal muscular atrophy. Well, a simple straightforward question, and this has been previously repeated as well. So the answer is Rett syndrome. Okay, Rett syndrome is X-linked dominant disorder. Let's quickly list down what are the other X-linked dominant disorders. Okay, what are the other X-linked dominant disorders in addition to the Rett syndrome? So you have got the X-linked hypophosphatemic rickets, X-linked hypophosphatemic rickets. Okay, X-linked hypophosphatemic rickets. Then you have incontinentia pigmenti, incontinentia pigmenti. Okay, then the syndrome, the Aicardi syndrome is there, Aicardi syndrome, fragile X syndrome, fragile X syndrome. So these are some of the X-linked dominant disorders which may be asked. So this also just keep in mind in addition to Rett syndrome. So Rett syndrome, you can expect questions based on Rett syndrome itself in your exams. So Rett syndrome is basically a neurodevelopmental disorder, and this is almost exclusively seen in females. And a very important gene mutation that you should know associated with Rett syndrome is the MECP2 gene mutation. Okay, so MECP2 gene mutation is associated with Rett syndrome. And patients with Rett syndrome, see, the initial development is normal, but subsequently what happens is there is loss of speech and there is loss of the purposeful hand movements. So what happens is the patient tends to have stereotypic hand movements, some gait abnormalities. So that is what happens in case of Rett syndrome. So in this question, straightforward question, X-linked dominant is Rett syndrome. Moving to the next question, all are features of complicated malaria except pH more than 7.2, unarousable coma, glucose less than 50 milligram percentage, serum creatinine more than 5.2 milligram percentage. So see, when it comes to malaria, especially the falciparum malaria, there are certain features that suggest that, okay, this is a complicated malaria. And one of such features is the unarousable coma. Okay, so that is not going to be the answer. Unarousable coma is definitely a feature of complicated malaria. Glucose less than 50 milligram percentage, yes, because hypoglycemia is a feature of complicated malaria. Renal failure is also a feature of complicated malaria. In addition to whatever I have mentioned so far, there are again features of complicated malaria. One is hypotension. So malaria patient in hypotension is again complicated malaria. Presence of convulsions, okay, presence of convulsions is again feature of complicated malaria. Presence of pulmonary edema, presence of pulmonary edema. Then when you have ARDS developing in the patient, this is also a feature of complicated malaria, and so is severe anemia. Okay, so these are features of complicated malaria. Regarding the first option, see, that is not a feature of complicated malaria. So how can I correct the option 1? See, it's not alkalosis, it is often acidosis. That is when the pH actually goes less than 7.25 and the patient goes on to have severe acidosis. That is when you say, okay, this is a complicated malaria. So the first one, it's not pH more than 7.2, it should have been less than 7.2, which is a feature of complicated malaria. Even in your Harrison textbook, you will find a table where they have listed the features of complicated malaria, and commonly it occurs with the falciparum malaria. Okay, all right. Next, again a simple straightforward question. Causes of central cyanosis are all except. So they have asked a question specifically on central cyanosis. So all the options given, methemoglobinemia, pulmonary AV fistula, hypothermia, high altitude, all can cause cyanosis. But when it comes to central cyanosis, let me show you again one very important, very high yield table from Harrison, which shows the features of central cyanosis and peripheral cyanosis. So in the options, see, high altitude definitely is associated with central cyanosis. Okay, the pulmonary AV fistulas again associated with central cyanosis. Methemoglobinemia again associated with central cyanosis. Okay, so you can see the causes of central cyanosis, but peripheral cyanosis, you see cold exposure that is classically associated with peripheral cyanosis. So when you have hypothermia, it is often associated with peripheral cyanosis. Okay, so the answer to this question is going to be option C. Okay, hypothermia is a cause of peripheral cyanosis and not central cyanosis. Next question, again a very good question. A patient presented with persecutory delusions and third person auditory hallucinations, and he was diagnosed to have schizophrenia. Okay, and the patient was prescribed risperidone 2.5 milligram to be taken daily, and next day this patient presented to the emergency with a persistent upward gaze for a few hours. Okay, what is the next step in management? So someone diagnosed with a schizophrenia started on antipsychotic, next day persistent upward gaze lasting for a few hours. What is going to be the management? Is it injection lorazepam, reassuring the patient, injection phenytoin, or injection promethazine? So what do you think has happened here? Well, see, often in entrance exams, they do ask you questions based on the side effects of antipsychotic drugs. And many times the examiners are inclined to asking questions based on the long-term adverse effects of antipsychotics. But here they have asked a question specifically on an acute adverse effect. See, when you administer an antipsychotic like risperidone, the patient can develop an adverse effect, an acute adverse effect in the form of acute dystonic reaction. What is it? They can develop acute dystonic reaction. Remember, I again stress on the word acute. Okay, acute dystonic reaction. All right. So this acute dystonic reaction means, see, in the form of involuntary contraction of the muscles, which may either involve the extremities, the face, neck, abdomen, pelvis, larynx. So you can have these involuntary muscle contractions that lead on to certain patterns of abnormal movements and postures, and you call that dystonia. Now, the most common causative agent for an acute dystonic reaction is, can you tell me what? It is antipsychotic and antiemetic agents. So, it's commonly associated with antipsychotic as well as antiemetic agents. Antipsychotic and antiemetic agents. And if you ask me, why does this acute dystonic reaction happen? This occurs because of a dopaminergic cholinergic imbalance of the basal ganglia. Okay, so that is the etiology. And though I gave a vague, broad term acute dystonic reaction, please understand, children, that this acute dystonic reaction can manifest in various ways. Okay, and one of the classical presentation is what is given in the question, that is known as an oculogyric crisis. Okay, it is one of the clinical presentations of an acute dystonic reaction where there is a spasm of the extraocular muscles, because of which the eyes are commonly upwardly deviated. So you can have the eyes in almost a persistent upward gaze, which is nothing but an oculogyric crisis due to the spasm of extraocular muscles. So what you have in question is a antipsychotic induced acute dystonic reaction in the form of an oculogyric crisis. And not just oculogyric crisis, you can have other acute dystonic reactions as well, like a buccolingual crisis where you have a trismus or a dysarthria, dysphagia. You can have a torticollic crisis where the patient can have an abnormal asymmetric head or neck position. So there are different crises, but the question that is given is regarding the oculogyric crisis. Now, what about the management? Because the question is on the next step of management. So I've already told you about the dopaminergic cholinergic imbalance. So in the management of this acute dystonic reaction, what you commonly give is anticholinergic agents. So they are going to come to the rescue. Which one? The anticholinergic agents. Okay, anticholinergic agents. So these agents are commonly used. And out of the options, you see injection lorazepam, reassuring, phenytoin, promethazine. See, the answer is going to be promethazine. Though it is an antihistamine, it is also having anticholinergic action. Though it is an antihistamine, it also has anticholinergic action. Hence, in this patient, you can use injection promethazine. Okay, very, very important. Now, I'm just showing you a table. This is taken from the Bradley textbook of neurology, which is the Bible of neurology. So you can see neuroleptic induced movement disorders. There can be acute movement disorders and chronic movement disorders. So the acute one is in the form of a dystonic reaction. You can also have certain other acute transient say movement disorders and also chronic persistent movement disorders, but examiner as of now is focusing on the acute dystonic reaction. Okay, crystal clear. All right, let's move to the next question. Any question paper of INI CET or Neet PG often asks some question related to potassium. It has to be there. So similarly here also they have asked a question regarding potassium, and commonly they ask regarding hyperkalemia. A very common question, not correct regarding hyperkalemia management. Injection regular insulin, injection magnesium sulfate, injection calcium gluconate, or inhalation of salbutamol. So simple straightforward question on the hyperkalemia management. See, a few points that you have got to know about the hyperkalemia management. Number one, see, the treatment of hyperkalemia, they have given in Harrison also that there are 3 stages in the management of hyperkalemia. So stage 1 is the immediate antagonism of the cardiac effects. Okay, is the immediate antagonism. It is the immediate antagonism of cardiac effects. Okay, so how do you do that? You are going to give the patient IV calcium gluconate. Okay, IV calcium gluconate. Remember, the purpose of giving IV calcium gluconate in hyperkalemia is not to reduce the potassium level, but to raise the action potential threshold and to reduce the excitability so that you don't get say life-threatening arrhythmias. So first is the immediate antagonism of the cardiac effects, number one. So number two, you have got to bring about a rapid reduction in plasma potassium concentration. Okay, a rapid reduction in plasma potassium concentration. Okay, so here a rapid reduction in plasma potassium concentration, this is often by a redistribution. Okay, so here you are giving the patient insulin as well as beta 2 agonist. Okay, insulin as well as beta 2 agonist. Okay, so giving insulin and beta 2 agonist lowers the potassium concentration. How? By shifting the potassium into cells. Okay, that is how it will lower the plasma potassium concentration, by redistribution. And number three is the removal of potassium. Okay, you are trying to remove potassium. So removal of potassium is accomplished by the various cation exchange resins. Okay, so you can use cation exchange resins, and also a procedure like dialysis. Okay, a dialysis, or even you can use even diuretics as well. So these are the important agents used in the treatment of hyperkalemia. Definitely regular insulin is not going to be the answer. Calcium gluconate, salbutamol, it's a beta 2 agonist, so the answer is going to be option B, that is injection magnesium sulfate. Okay, all right. Now the next question, choose the correct match about the serology of chronic hepatitis B. Okay, so the question is on chronic hepatitis B. So they have given the various parameters like HBsAg, anti-HBsAg, IgG, anti-HBc and HBV DNA. So a very simple question here. So it's chronic hepatitis B. So tell me children, for a patient to have chronic hepatitis B, HBsAg should be what? It should be positive. In someone, you know, HBsAg negative, you cannot go for a chronic hepatitis B diagnosis. So obviously in this option A as well as option C, you can straight away rule out, because in them HBsAg is negative. Now next, coming to anti-HBsAg. See, anti-HBsAg is a protective antibody. So in case of chronic hepatitis B, you will not have the protective antibody developing. So the anti-HBsAg will be negative. So you look at the second option, you can see that the option D as well as option B, in case of chronic hepatitis B, anti-HBsAg will be negative. So the option B, where anti-HBsAg is positive, is definitely not going to be the answer. IgG anti-HBc, yes, it will be positive, because let me just show you the figure from Harrison on the serological pattern of a chronic hepatitis B. You can see the HBsAg is persisting. The IgM anti-HBc will come down, whereas the IgG anti-HBc is going to persist. The HBV DNA is going to persist, especially during the replicative phase of hepatitis B. So the option D, okay, the option D, which is a positive HBsAg, negative anti-HBsAg, IgG anti-HBc positive and HBV DNA positive, that is going to be the serology of chronic hepatitis B. Okay, very simple. So this table from Harrison, which I am just going to show you, the commonly encountered serologic patterns of hepatitis B infection. This is very important, because this is one hot favorite table of the examiners for the exams. So you can get varied combinations of the various parameters like HBsAg, anti-HBs, anti-HBc, HBeAg, anti-HBe. So expect again questions from this topic. So you have got to be very thorough. So in the Hepatitis B lecture in the app. I have covered in detail about the serological markers of hepatitis B. So have a very good conceptual knowledge regarding that. Okay, all right. Again, coming to a simple straightforward question which is correctly matched with their side effects. Aliskiren hypokalemia, atenolol hemolytic anemia, verapamil constipation, hydralazine heart failure. So again, a very simple straightforward one. What is the answer? It is verapamil constipation. Verapamil is a calcium channel blocker, and constipation is a common side effect of verapamil. But the other calcium channel blockers, constipation is less common. It's more prominent with verapamil. What about aliskiren? See, aliskiren is a direct renin inhibitor which is going to block the active site of renin. So it will block the conversion of an angiotensinogen to angiotensin 1, and thereby it reduces the consequent production of angiotensin 2. And remember, aliskiren is going to produce hyperkalemia and not hypokalemia. Okay, and atenolol is not going to produce any hemolytic anemia. Hydralazine is not going to cause heart failure. In fact, hydralazine is used in the treatment of heart failure, especially as a combination pill containing the isosorbide dinitrate. That is a combination of hydralazine and isosorbide dinitrate. The combination pill is used in the treatment of heart failure because it relaxes the arteriolar smooth muscle also. So this option is also wrong. So the answer is verapamil constipation. Next question, which clotting factor is reduced in pregnancy? Again, a very factual question. So options are 7, 9, 11 and 12. So just look at this table on the coagulation changes in pregnancy. Okay, on the coagulation changes in pregnancy. Coagulation changes in pregnancy. So clotting factor and the changes in pregnancy. So you can see that the clotting factor 2 is unchanged, 7 and fibrinogen increased, 8, 9, 10 and 12 is increased, but very important, you see clotting factor 11 is reduced. Protein S is reduced, C and antithrombin 3 unchanged, plasminogen increased, D dimer increased. So in this question, which clotting factor is reduced in pregnancy? It is going to be 11. 7, 9 and 12, you can see 7, 9 and 12, they are all increased in pregnancy. So this is a simple, straightforward, factual question. Okay, all right. Coming to the next question, AIDS defining tumors are all except Kaposi's sarcoma, melanoma, invasive cervical carcinoma and non-Hodgkin's lymphoma. First of all, you have got to have an idea on this terminology, AIDS defining conditions. Okay, so what are these AIDS defining conditions? Okay, AIDS defining conditions. Okay, see, AIDS defining conditions are a list of conditions which include opportunistic infections and neoplasms. Okay, both. So this list of conditions, when any of them occur in the setting of an HIV infection, this confirms the diagnosis of AIDS, which is a severe HIV infection. And these AIDS defining conditions commonly occur in patients with AIDS. They are less common in immunocompetent individuals. I am not saying that all the AIDS defining conditions occur exclusively in HIV positive patients. They can occur in otherwise also, but generally more common in case of immunocompromised individuals. Okay, so this AIDS defining conditions, specifically the examiner is asking about AIDS defining tumors. So what are the tumors which are AIDS defining conditions? Kaposi's sarcoma definitely is an AIDS defining tumor. Remember, the examiner is asking all except. Invasive cervical carcinoma is definitely an AIDS defining condition. Non-Hodgkin's lymphoma is an AIDS defining condition. So the answer is going to be melanoma. But I want you to know, an extra fact here. that even melanoma also there is a higher propensity to occur in patients, HIV positive patients, but it is not grouped under AIDS defining condition. You see here in this is a screenshot from Harrison. So that neoplastic diseases which are considered to be AIDS defining conditions, they are Kaposi sarcoma, non-Hodgkin's lymphoma and invasive cervical carcinoma. In addition, there is also an increase in the incidence of a variety of non-AIDS defining malignancies, including Hodgkin's disease, multiple myeloma, leukemia, melanoma and cervical, brain, testicular, oral, lung, gastric, liver, renal and anal cancers. But remember, they are not AIDS defining, they are non-AIDS defining malignancies. Okay, but still there is still an increased incidence. So this question answer is going to be melanoma. Okay, and this is the big list in Harrison that you have on the entire list of AIDS defining opportunistic infections as per the CDC. Okay, so CDC stage 3 is the AIDS, and the entire list of infections and neoplasms, they are actually, infections they have actually mentioned in this table. Very, very important. All right, then next question. HIV positive mother on antiretroviral therapy has delivered a baby. Choose the correct statement. Exclusive breastfeeding and nevirapine even if child is HIV negative. Formula feeds and nevirapine even if child is HIV negative. Exclusive breastfeeding and nevirapine if child is HIV positive. Formula feeds and repeat HIV testing at 6 weeks. So this is again a relatively easy question, because see, in patients with who are actually HIV positive mothers, they are delivering baby. First point that you should know is that EBF or exclusive breastfeeding for 6 months is advised. Okay, exclusive breastfeeding for 6 months is advised, and even beyond the 6 months of age, the breastfeeding should continue while the complementary feeds are introduced. Well, the guidelines, they say that at least for 12 months they should breastfeed and preferably continue for 2 years. Okay, but at the same time, the patient is being supported by the mother is being supported by the antiretroviral therapy. But for 6 months exclusive breastfeeding, you still bring in the complementary feeds after 6 months, continue the breastfeeding for 12 months, ideally for 24 months. That is what should be done. So this first statement of mine itself rules out 2 options, option B and option D, regarding formula feeds. Okay, so you don't want to have formula feeds in the patients, and the guideline also says, the national guideline also says, mixed feeding, that is both breast and the formula feeds, especially in the first 6 months, that will increase the risk of transmission of HIV, and mixed feeding also should be avoided. So the option is either A or C, exclusive breastfeeding. Okay, so that is definitely A or C. And just let me show you this table. This again is taken from the national guidelines. So you see here, this is the antiretroviral intervention and the risk of HIV transmission. Now, if the mother is, if there is no ARV that is being given and breastfeeding is continued, then there is a 30 to 45% risk of transmission from mother to child. No ARV, no breastfeeding, then 20 to 25% chance. But you see, when the mother is actually supported by antiretroviral therapy, then look at the difference with breastfeeding and without breastfeeding. With breastfeeding is 2%, without breastfeeding is 1%. So there is no significant difference. All you have got to do is give the mother proper antiretroviral therapy, or I can also say that, quoting the guidelines, let me tell you, breastfeeding is made safe breastfeeding is made safe by giving the ART to the mother and ARV prophylaxis to the baby. That is how you make the breastfeeding safe. And remember, all HIV positive pregnant women, okay, including those who are presenting in labor or breastfeeding, they should be started on a triple drug antiretroviral therapy. This is regardless of the CD4 count and the clinical stage. So the basic essence is treat all. This is to prevent the mother to child transmission, and you should continue lifelong antiretroviral therapy. Now, what about the antiretroviral prophylaxis? So, see, to an infant, definitely ARV prophylaxis is advised, and this prophylaxis is based on the risk of HIV transmission. So, you categorize infants to low risk of transmission, low risk infants and high risk infants. So, in case of low risk infants, you go for single drug ARV prophylaxis, either syrup nevirapine or syrup sidovudine. Whereas in case of high risk infants, you will actually go for dual ARV prophylaxis is advised. So that is with a combination of syrup nevirapine and syrup sidovudine. Okay, so that is important again. So coming back to this option, see, exclusive breastfeeding is given, and the nevirapine prophylaxis is not based on you going and again checking the child if the child is HIV positive or negative. No. So even if the child is HIV negative, you have got to give nevirapine prophylaxis. So exclusive breastfeeding and nevirapine, even if child is HIV negative, that is the correct statement. Okay. So this again is an expected question. Okay. Moving to the next question. A patient was admitted to the hospital with unknown poisoning. He had symptoms of nausea, vomiting, excessive salivation, lacrimation, muscle cramps and seizures. Which of the following will you administer to the patient? Options are flumazenil, beta blocker, atropine and calcium gluconate. So this is the case scenario of an unknown poisoning. So just have a look at the symptoms of this patient. Okay, nausea, vomiting, salivation, lacrimation, muscle cramps and seizures. Well, in the context of an unknown poisoning, all these symptoms are suggestive of an organophosphate poisoning. Okay, because I'm sure that in organophosphorus poisoning, the patient manifests with features of acute cholinergic excess. So this is a case scenario of an organophosphorus poisoning or OP poisoning, where the patient presents with features of what? Cholinergic excess. Okay, patient presents with features of cholinergic excess. Okay, so this is acute toxicity. Now, whenever a patient has an organophosphate poisoning, he will have features of both muscarinic symptoms and signs and nicotinic symptoms and signs. So muscarinic symptoms will be in the form of excessive secretions, which can be lacrimation, salivation. So along with that, you can also have features of nausea, vomiting, diarrhea, even urinary and fecal incontinence. You can expect all these as the muscarinic signs and symptoms. Whereas you can also have nicotinic signs and symptoms. So cholinergic excess in the form of muscarinic signs and symptoms, and also nicotinic signs and symptoms. Okay. So nicotinic signs and symptoms, you can have tachycardia, hypertension, weakness, muscle cramps, fasciculations. So those symptoms can also occur. So here the patient is presenting with features of cholinergic excess, and which is why most likely this is a case scenario of organophosphorus poisoning. Now when you have a OP poisoning, how are you going to manage the patient? Okay, how are you going to treat the patient? So first of all, you have to administer oxygen to the patient. Yes, important. You have got to give the supportive care and check the airway breathing circulation. Supportive care, check the airway breathing circulation. And then I told you, you can have muscarinic signs and symptoms. So you need a muscarinic antagonist. And what is that muscarinic antagonist? It is atropine. Okay, it is atropine. You have got to give the patient adequate fluids. Okay, adequate fluids. And see, you've got to give the patient an acetylcholinesterase reactivator. So what is the acetylcholinesterase reactivator that you will give the patient? It is nothing but pralidoxime. Okay, you will give the patient pralidoxime. So this oxime is something that will reactivate the acetylcholinesterase by the removal of the phosphate group. Okay, so that is how it acts. And in case the patient develops seizures, you will give the patient benzodiazepines. Okay, in case the patient develops seizures, you will give the patient benzodiazepine. Okay, so this is the part of the treatment. And also it goes without saying that all the clothes that the patient was wearing, you have got to remove them, because absorption can occur by, like, in case the chemical has contaminated the clothes, absorption can also occur via that. So that also you have got to remove. So for this question, you've got to administer atropine to the patient. So option C is going to be the answer. Next question, what is the ratio of T cells and B cells in the peripheral blood? Again, a hematology question. Well, let me just show you a screenshot from the Robbins textbook. So the Robbins textbook says the mature T cells are around 60 to 70%, whereas the B lymphocytes are 10 to 20%. So if you take the ratio, it's around 60 by 20, which is almost 3:1. You will see in certain textbooks they have given the ratio as 4:1. So the answer to this is 3:1. See, some students were telling me that there was no option of 3:1 and it is 4:1 that was there in the option. So I'm not sure exactly what the option was, but whether it is 3:1 or 4:1, you pick either of this. I'm sure that both of them together would not have been present in the options. So the answer here for this question will be 3:1. Okay, all right. Next question on basic immunology. MHC class 1 binds to the antigen and activates. Is it helper T cells, cytotoxic T cells, B cells, or NK cells? Well, see, the CD8 T cells or the cytotoxic T cells, they are recognizing the peptides that are presented by the MHC class 1 molecule. So there is an interaction between the CD8 molecule on the surface of T cells and the non-peptide binding regions of the MHC class 1 molecule. So the answer for this question is going to be cytotoxic T cells. At the same time, remember that the helper T cell, the CD4 helper T cell, they will recognize and respond to antigen displayed by the class 2 MHC molecule. So class 2, it is CD4 T helper cells. Class 1, it is cytotoxic T cells. Okay. Yes. Next question, most common pattern of involvement of port spine. So you can take this to be a neurology question because TB of the spine is very important. So this port spine is nothing but the tuberculous spondylitis, okay, or the spinal tuberculosis. That is what is this port spine. And there are different patterns of involvement of the spinal tuberculosis. Let me just show you a diagrammatic representation. So there are different patterns. The most common one is going to be the paradiscal pattern. Okay, paradiscal pattern, where the adjacent vertebra and the intervening disc is involved, and that is the most common. Okay, the most common is the paradiscal pattern. What are the other ones? You have got the central pattern. Okay, you have got the anterior one, anterior, and also you have got the posterior. Okay, anterior and posterior. So these are the patterns of involvement of port spine or the tuberculous spondylitis, but the most common one is the paradiscal. Okay, so the answer is option A. Okay, all right. Next question, a question from rheumatology. All the following are first line drugs for rheumatoid arthritis except methotrexate, sulfasalazine, hydroxychloroquine, azathioprine. Well, in my video lectures also, I have taught you regarding the 2021 ACR guidelines for the treatment of rheumatoid arthritis, and I have also given you the list of agents which are available for the treatment. So you see the different class of agents available for treatment of rheumatoid arthritis. Number one, you have the conventional synthetic disease modifying anti-rheumatoid agents, which includes hydroxychloroquine, leflunomide, methotrexate, sulfasalazine. Then you have the targeted synthetic DMARDs, which includes baricitinib and tofacitinib. Then you have the category of biological DMARDs, and in the biological DMARD category you have one is the group of TNF alpha inhibitors, which includes the adalimumab, certolizumab, etanercept, golimumab. So that they are the TNF alpha inhibitors, and even infliximab also. Then the anti-B cell or anti-CD20, which is rituximab. Then anti-T cell co-stimulation agent, that is abatacept, and anti-IL-6 agent, which is sarilumab and tocilizumab. So these are the agents available for the treatment of rheumatoid arthritis. And coming back to the question, yes, methotrexate is a first line agent, sulfasalazine is a first line agent, hydroxychloroquine is a first line agent, but azathioprine is not a first line agent. Okay, answer is option D. Coming to the next question, the given polysomnographic recording is suggestive of which stage of sleep? Is it REM sleep, NREM sleep stage 1, NREM stage 2, or NREM stage 3? So they have given EEG recording, the polysomnography recording as well. So for those students who are having some doubts on what is basically a PSG, let me tell in very simple words. Polysomnography is a very important investigation in the laboratory evaluation of sleep. And when you do a polysomnography, there are two main purposes why you are doing the polysomnography. Okay. So one is it helps in determining the sleep stages. Okay. So it helps in sleep staging, which again has its own clinical implications. So for sleep staging, in a polysomnography, what helps is you have the EEG, the EOG and the EMG. EEG, EOG and EMG actually helps in sleep staging. Then see, in addition to that, the various physiological parameters, in addition to sleep staging, the various physiologic parameters, they are also important. So the various physiological parameters include the ones like breathing, circulation, movement. So all these are there. So these two are the basic purposes of a polysomnography, and it has clinical utility in various sleep disorders. And see, the recording that you would get will be like this on your monitor screen. The patient is actually sleeping with all the electrodes and the other connection devices. You have got the EOG recording, EEG recording, EMG recording, the basic ECG recording, then the snoring sensors, nasal pressure, thermistor, the you have belts which look for movements of the thorax and abdomen. Especially it is useful in the differentiation between central sleep apnea and the obstructive sleep apnea, and also SpO2. So multiple physiologic parameters are measured in the polysomnography. And let me tell you that for sleep staging it is also very important. And for this question they have asked regarding the stage of sleep. Well, usually this is not a typical question that should be asked for a post MBBS student. This is my perspective. See, this is something that usually medicine residents learn during their residency and also during the super specialty. And for me personally, I don't think an MBBS graduate is supposed to know this, but however the question has come. So the answer to this is actually REM sleep. Okay, the answer to this question is REM sleep. So let me tell you why this is a REM sleep. Okay, first of all, know that, see, I already told you, you have got EEG, EOG and EMG recordings. So in case of a REM sleep, what does the EEG tell you? The blue line, it actually shows low amplitude mixed frequency sawtooth waves. Okay, so in case of the REM sleep, you get low amplitude mixed frequency sawtooth waves. Okay, sawtooth waves. And EOG, you are seeing the deflections here. Yes, you are seeing the deflections here. So you are going to get rapid eye movements. Okay, you are going to get rapid eye movements in EOG, electrooculogram. Okay, EOG is electrooculogram. And in EMG or electromyogram, see, there is absent muscle activity, or I can say that there is muscle atonia. Okay, so there is absent muscle activity. So so you have got the chin electrodes which are placed on the chin for the EMG recording. And let us have a look at the polysomnographic recording which was actually given for the question. So the top ones, they are the, let me just show you the top ones, these four. These are the EEG recordings which is showing the low frequency, low amplitude, mixed frequency sawtooth waves. And in EOG, if you see, this is left eye and the next is the left and the right. And here again in the EOG, it is shown in the box also the deflections of the rapid eye movements. So these deflections that you are seeing here is corresponding to the rapid eye movements which has been encircled in the box. These are the EOG recordings. And if you look at the chin EMG recording, you are seeing more or less a flat line corresponding to the absent muscle tone or muscle atonia. So, and again you can see the other parameters as well, but again for sleep staging this alone is enough. Just having a look at the EEG, EOG and EMG is enough, and the answer for this is the REM sleep. Okay. Coming to the next question, choose the false statement about primary prophylaxis for opportunistic infections in HIV patients. Option A, prophylaxis against the MAC is started when the CD4 count is less than 50. Prophylaxis against the pneumocystis is started when CD4 is less than 200. Prophylaxis for cryptococcal disease is started when the CD4 count is less than 150. And prophylaxis for the PCP is stopped when the CD4 count is more than 350 on 2 occasions 6 months apart. Well, let me tell you to begin with that the CD4 T cell count or the CD4 count is a very important indicator of the immunologic competence of a patient with HIV infection. And when you talk of opportunistic infections in HIV patients, you can give the patient primary prophylaxis as well as secondary prophylaxis. Primary prophylaxis means it is the prophylaxis that you give, the drug is given before the appearance of opportunistic infection, whereas secondary prophylaxis, the prophylaxis is given after the appearance of the opportunistic infection. That is primary and secondary. So here the question is specifically on the primary prophylaxis. And see, the first option, the prophylaxis for the Mycobacterium avium started CD4 count less than 50. It is again a true statement, so that is not going to be the answer. They have asked a false statement. Against PCP at a CD4 count less than 200, it's again a true statement, so that is not going to be the answer. And for the next one, cryptococcal disease. Now this one is slightly interesting. Let me show you a screenshot from the guideline. This is the National Guidelines for HIV Care and Treatment 2021. So for primary prophylaxis in case of cryptococcal disease, so generally it is not recommended. The prophylaxis for cryptococcal is not recommended because of the relative infrequency of the cryptococcal disease, lack of survival benefit associated with prophylaxis, possibility of drug interaction and potential antifungal drug resistance. So generally primary prophylaxis is not given for cryptococcal, but there is an exception, that is when the cryptococcal antigen test is not available, you may consider primary prophylaxis, and that also when the CD4 count is less than 100. So definitely this option C is a false statement and you can select that as the answer. But let me also tell you one thing. When you have a look at Harrison, in one part in Harrison, even in the 21st edition, they have said that they have not quoted the national guideline. In fact, Harrison is an international book. But for the international book like Harrison, they have stated that, okay, you can consider cryptococcal prophylaxis when the CD4 count goes less than 200. Okay. But I think for a condition like AIDS and HIV, you have got to follow the Indian guidelines, especially in our context questions. Okay. So we have definite solid guidelines by the NACO. So you have got to study that only. Okay. And which is again very important. So let's go to the last option as well. Prophylaxis for PCP is stopped when the CD4 count is more than 350 on 2 occasions, which is also absolutely correct because this is a direct screenshot from the guidelines. The duration of quatrimoxazole prophylaxis for PCP, not the duration, discontinuation. When the CD4 count is greater than 350 on 2 different occasions tested 6 months apart, with an ascending trend and devoid of any WHO clinical stage 3 or stage 4 conditions. Okay. So the last option is also a true statement. Okay. So, and this is something where you have got to follow the Indian guidelines. Okay. So the option C is what you have got to choose here. Okay. All right. Because if you look at multiple guidelines, you are got to be confused. Even option B also, there is a different guideline that says a different value. So this is what you have got to follow. Okay. All right. Now coming to the next question, again a neurology question. Arrange in sequence the direct pathway of the basal ganglia. I have explained to you in my lectures this specific question. So I think everybody would have got this right. That is what I assume. So basal ganglia circuit, okay, when you talk of basal ganglia circuit, it has actually 2 pathways, okay, actually 3 pathways to be precise, but mainly 2 pathways, which is the direct pathway and the indirect pathway, though you also have a hyperdirect pathway. Let's first see the direct and indirect pathway. So you call one direct and indirect depending upon whether the striatal outflow is directly communicating with the substantia nigra, pars reticularis and the GPI, or it first goes to the globus pallidus externa and subthalamic nucleus before terminating in the GPI SNR. Okay. So that is what is this direct pathway and indirect pathway. But both these pathways will then go to the thalamus and from there to the motor cortex. So motor cortex striatum to SNR GPI, either directly or an indirect path. So this is the direct pathway. Okay. And this one is the indirect pathway. Both of them go to the thalamus and from there back to the cortex, completing the loop. There is also another pathway which is known as the hyperdirect pathway, where it bypasses the striatum. Directly from the frontal cortex, it comes to the subthalamic nucleus, from there to the SNR, GPI, thalamus and back to the cortex. So that is the hyperdirect pathway. So remember, the direct pathway is involved in thalamocortical facilitation. Okay. So direct pathway is involved in thalamocortical facilitation. Okay. So when you have a thalamocortical inhibition, that happens when there is a damage to the direct pathway, as in case of Parkinson's disease. Whereas the indirect pathway and hyperdirect pathway, it is mainly concerned with the thalamocortical inhibition. Okay. So they have asked regarding the sequence of the direct pathway. Okay. Sequence of the direct pathway. So sequence of the direct pathway, I have told you that from the striatum, it goes to the GPI and SNR, thalamus and to the cortex. That is first one. Okay. The remaining ones are wrong. So the option 1 is the correct sequence of the direct pathway of the basal ganglia. Okay. All right. So next question is a question which is linking medicine and biochemistry, which of the following amino acids is not restricted in the management of maple syrup urine disease, which is MSUD? Is it leucine, isoleucine, valine, or methionine? See, this maple syrup urine disease is an autosomal recessive disease, which is also referred to as branched chain ketoaciduria. Okay, what is it also known as? Branched chain ketoaciduria. Branched chain ketoaciduria. And this condition is caused by a deficiency of the branched chain alpha ketoacid dehydrogenase complex. So there is a deficiency of the branched chain alpha ketoacid dehydrogenase complex. And what you have got to do in case of maple syrup urine disease is that you have got to restrict the branched chain amino acids in the diet, okay, which is very, very important. So what are the branched chain amino acids? You have got the leucine, isoleucine, and valine. So leucine, isoleucine, and valine has to be restricted, and which is the amino acid which need not be restricted? It is methionine. Okay, so option D is the answer. So next question, which is the active metabolite of cyclophosphamide? N-methyl cyclophosphamide, N-acetyl, 4-hydroxy, 4-acetyl cyclophosphamide. Well, this agent cyclophosphamide, okay, cyclophosphamide is an alkylating agent which is used in various malignancies, both hematological as well as solid tumors. It is used in autoimmune diseases, it is used in vasculitis. And this drug cyclophosphamide, as many of you know, is a prodrug, okay, is a prodrug. And this requires metabolic activation by the various cytochrome enzymes. And let me just show you a figure which I have taken from Goodman-Gilman. You can see cyclophosphamide is metabolized by the cytochrome enzymes. And what is this active metabolite? 4-hydroxy cyclophosphamide. You also have the formation of aldophosphamide, and subsequently, it is then metabolized to various inactive metabolites and toxic metabolites in case of excess. But remember, 4-hydroxy cyclophosphamide is one of the active metabolites of cyclophosphamide, and the answer is option C. Okay, 4-hydroxy cyclophosphamide. It again just goes to show that this INI-CET paper had a bit more factual question than the usual paper. So the message I want to tell all my dear students is, see, when you are preparing for an exam, whether it be NEET PG or INI-CET, you've got to have a good range. That is, you should be very thorough in your basics. Yes, you should have a good hold of the factual questions, and also you should be in a position to answer the clinical oriented questions as well, because question patterns can keep slightly changing, okay, but majority of the question come in the clinical scenario form. That question is also very clear. Okay, coming to the next question, a patient who presented with prolonged fever and splenomegaly is tested positive for RK39 antigen test. Okay, RK39 antigen test. This patient should be treated with, is it liposomal amphotericin B, ivermectin, praziquantel, or fluconazole? So in the setting of a patient with a prolonged fever and splenomegaly, the examiner is trying to test whether you know of this antigen test, that is the RK39 antigen test, which is actually a rapid immunochromatographic test which detects the antibodies to a recombinant antigen, which is the RK39, recombinant antigen, that is RK39. So 39 because it consists of 39 amino acids. So this immunochromatographic test is just a simple blood investigation, and this test you get with a result within 15 to 20 minutes. You get the result. And the advantage of this test is that this test has got a high sensitivity and specificity. Okay, high sensitivity and specificity. And this test is for which condition? This test is for visceral leishmaniasis. Okay, visceral leishmaniasis. Visceral leishmaniasis. So for visceral leishmaniasis, you will treat the patient with what? Liposomal amphotericin B. Okay. But remember, though this is an immunochromatographic test, what is the gold standard for the diagnosis of visceral leishmaniasis? It is going to be the demonstration of the A mastigotes in the smears of the tissue aspirates. So you can go for either the splenic tissue. Okay, you can go for the splenic smears. In fact, the splenic smears, the sensitivity is above 95%. So splenic smears, demonstration of A mastigotes, very high sensitivity. Followed by you have bone marrow, where the sensitivity is around 60 to 85%. Followed by the lymph node aspirates, okay, where the sensitivity is roughly around 50%. Okay, so these are some of the extra points that I want you to know. For this question, the answer is going to be liposomal amphotericin B. Okay. Coming to the next question. A patient presented to the emergency department following a road traffic accident. His GCS was 3. The CT scan was normal. What is the most likely diagnosis? Subarachnoid hemorrhage, diffuse axonal injury, cerebral contusion, extradural hemorrhage. So this again is a question you definitely can answer. See, CT scan showing a normal study with a very poor GCS, because out of the total 15 points that is there, it's just 3 out of 15. So the patient is definitely comatose. And do you think a subarachnoid hemorrhage is going to have a normal CT? No. Extradural hemorrhage? No. Even cerebral contusion also you will have imaging finding. So the answer definitely, even by exclusion, has got to be a diffuse axonal injury. So what is this diffuse axonal injury, which you can abbreviate as DAI? So this diffuse axonal injury is a type of traumatic brain injury that results from a blunt injury to the brain. And the most common etiology of the diffuse axonal injury is often involving high-speed motor vehicle accidents. So interestingly, what happens is there is either a acceleration or a deceleration injury, or even you can say rotational injuries, and this will cause a shearing injury to the white matter pathways. Very, very important. So because of the accelerating or decelerating or rotating forces, there is a shearing injury to the white matter pathways. Shearing injury to the white matter pathways, right? And that is what causes the damage. So you will suspect a diffuse axonal injury when a patient is having a traumatic brain injury and the patient has a very poor GCS. And as I already told you, it is affecting the white matter tracts, especially of the corpus callosum and the brainstem. And remember, a severe diffuse axonal injury can lead on to PVS. What is PVS? A persistent vegetative state as well. Okay. So patients with diffuse axonal injury, they can present with a bilateral neurologic deficits, and which can affect different parts of because of the affection of different parts of the brain. Commonly, it's the frontal and temporal white matter, and also corpus callosum and brainstem I've already discussed with you. And just want to share a few points about the neuroimaging of this entity diffuse axonal injury as well, because CT scan is normal here. Please understand, generally in diffuse axonal injury, the changes on structural imaging are very subtle. Okay, so few millimeter size lesions, and such very small lesions are usually not detected on a CT, and often more sensitive imaging modalities for detection of the diffuse axonal injury. One is MRI, and then is DTI, or the diffusion tensor imaging. Okay, diffusion tensor imaging, diffusion tensor imaging. So these are the more sensitive imaging modalities. So when you take MRI, you can see foci of hyperintensities, especially in the T2 and the flare sequences. You also can see some microbleeds, that is some foci of hemorrhage, you can see that. And in MRI, for the detection of microbleeds, which sequence will you look for? Either the gradient echo sequence or the susceptibility weighted sequence. These are the ones more sensitive. So that's it about the imaging findings in case of diffuse axonal injury. So straightforward question. Answer is diffuse axonal injury. So next question, there is a bit of a pediatrics overlap as well here. So 2-year-old male presented with recurrent bloody stools, atopic dermatitis like rash and petechiae. CBC shows normal WBC count, platelet count of 20,000. What is the next step? So rashes, petechiae, recurrent bloody stools, thrombocytopenia. This is what usually catches your attention first. So you might have a tendency to believe, okay, it is due to the thrombocytopenia. So could this be ITP? But again, two other statements should take your attention. One is 2-year-old male and atopic dermatitis like rash. Specific mention of atopic dermatitis like rash. Well, this actually occurs, this combination or this constellation of clinical findings occurs in the disorder that is Wiskott-Aldrich syndrome. Okay, Wiskott-Aldrich syndrome. So Wiskott-Aldrich syndrome is an X-linked disorder which occurs due to a mutation in the WASP gene. Okay, so there is a loss of the WASP protein function which results in adaptive and innate immunodeficiency. So it's not only the adaptive, even the innate immunity is being affected. And what is the significance of this protein, that is the WASP protein and the WASP gene? So the WASP is actually regulating the actin cytoskeleton, and because it regulates the actin cytoskeleton, this has an important role in many of the lymphocyte functions, including the cell adhesion and migration. So also it is important for the formation of synapses between the antigen presenting cells and the target cells. This goes to show why a mutation in the WASP gene can have profound effects. And this can lead on to different manifestations in Wiskott-Aldrich syndrome. Number one, you can have recurrent bacterial infections, obviously because your innate and adaptive immunity is affected. And in addition to the immunodeficiency, very important, these patients can have eczema, and the eczema in patients with Wiskott-Aldrich syndrome, very important, resembles a classic atopic dermatitis. Okay, and in addition to that, patient can also have bleeding tendency caused by the thrombocytopenia. Also, patients are at increased risk of autoimmune disorders and malignancy as well. And diagnosis is straightforward here. It is Wiskott-Aldrich syndrome. But what is the question? The question is on the next best step. Remember, to establish the diagnosis of Wiskott-Aldrich syndrome, you have got to go for intracellular immunofluorescence analysis of the WASP protein. So the WASP genetic testing is what you should actually go for. So option is B. Okay, all right. So next question, which of the following drugs is safe for a 40-year-old chronic alcoholic who presents with seizures and altered sensorium with an AST of 180, ALT of 150 and GGT of 560? So which drug is safe? Well, very important, benzodiazepines. You have got to know that the elimination of most of the benzodiazepines involves metabolism by the liver enzymes, including the cytochrome pre-450 enzymes. And the benzodiazepine oxidation is definitely decreased in patients who are having liver disease. So in such patients, if you give those benzodiazepines, that is going to result in excessive sedation and respiratory depression. So what are the benzodiazepines you can give safely in case of liver disease? One is lorazepam. Okay, one is lorazepam. Second is oxazepam, and the third one is temazepam. Okay, temazepam. Okay, so lorazepam, oxazepam, temazepam. So these are the drugs. So these drugs, remember, they commonly undergo the extrahepatic conjugation, which is why you can go for these drugs in liver disease. For the answer is lorazepam, because in this chronic liver patient, alcoholic patient, you have got a deranged liver enzyme. You have got to prefer lorazepam and not other benzodiazepines like diazepam, clonazepam or alprazolam. Okay, all right. So next question, this is regarding a 30-year-old pregnant female who developed severe postpartum hemorrhage and then has presented with palpitations and dizziness, which subsequently went into a hypotensive shock that was refractory to fluid resuscitation. On examination, she is having cold, clammy extremities, heart rate of 140 per minute, BP of 60 millimeter systolic. Which is the next important step in the management of the patient? Is it growth hormone, thyroxine or hydrocortisone? So first of all, let's have a look at the diagnosis part. So the context is that of a severe PPH, patient developing features of palpitations and dizziness, obviously patient going into shock. But read this line again, it's a hypotensive shock that is totally refractory to fluid resuscitation, and the patient is having cold, clammy extremities, tachycardia, hypotension. Well, this is a scenario where you should be thinking of an acute vascular involvement of the pituitary, which is called a Sheehan syndrome. Okay, Sheehan syndrome. So what is this Sheehan syndrome? It is an acute hypopituitarism, often acute, but sometimes it can be a late manifestation as well. In this scenario, it's an acute hypopituitarism where there has been an infarction of the pituitary gland that commonly occurs after a postpartum hemorrhage. That is, after a heavy blood loss in PPH, you can have infarction of the pituitary gland, in this case leading on to an acute hypopituitarism. Okay, so the scenario is that of a Sheehan syndrome, and in case of such an emergency, what is the most important step? You've got to supplement hormone. Which hormone? It has to be hydrocortisone. I'm not saying growth hormone supplementation and thyroxine is not important, but first try to supplement hydrocortisone. Okay, so this in Sheehan syndrome as well as in pituitary apoplexy, you have got to give the patient hydrocortisone. And always remember that in pregnancy, what is the change that happens to the pituitary? There is a normal enlargement of the pituitary gland. This is in response to the estrogen stimulation. And you have a hypervascular gland in pregnancy, which is very much vulnerable to arterial pressure changes and very prone to hemorrhage which is why the infarction can occur. And what is the pituitary apoplexy entity? What it is? It is slightly different. It means bleeding into the pituitary gland. Pituitary apoplexy means bleeding into the pituitary gland, which can either occur in the context of a pre-existing pituitary adenoma, also in the setting of other comorbidities like diabetes, hypertension, sickle cell anemia, like that. Okay. Remember, pituitary apoplexy is an endocrine emergency where the patient can present with headache, visual symptoms, hypoglycemia, hypotension, and again a shock. Okay. So here also the answer is clear. Next question is a bit of a controversial question, and I want you to listen very carefully to this. The oral hypoglycemic agent with tendency to cause bone fracture in females. Canagliflozin, voglibose, rosiglitazone, and retatrutide. Okay. So let's see option one by one. First of all, canagliflozin. What is canagliflozin? It is a SGLT2 inhibitor. Okay. It is a SGLT2 inhibitor. And what is voglibose? It is a alpha glucosidase inhibitor. Alpha glucosidase inhibitor. Rosiglitazone is a thiazolidinedione. Okay, it is a thiazolidinedione. And liraglutide is a GLP-1 receptor agonist. Okay, GLP-1 receptor agonist. Now coming to the tendency to cause bone fracture, let me just discuss regarding two group of drugs. First I want to throw some light on thiazolidinediones, and I'm sure you know that the thiazolidinediones, they reduce the insulin resistance by binding to the PPAR gamma, okay, which is the peroxisome proliferator activated receptor gamma. But remember, there is a problem with this thiazolidine group of drugs, thiazolidinedione group of drugs. The first screenshot I am showing you is from Harrison textbook 21st edition. You can see that there is a increased risk of fractures associated with the use of thiazolidinediones, especially in postmenopausal women. Okay, especially in postmenopausal women. Let me also show you another screenshot, this time from the Goodman-Gilman textbook of pharmacology. Treatment with thiazolidinediones is associated with increased risk of bone fracture in women, and some studies also showing in men. So there is a definite association with thiazolidinediones and fracture risk in females. Okay, in females. Okay. Now having said that, let me also tell you that the group of the SGLT2 inhibitors, okay, so which are the sodium glucose co-transporter inhibitors. Now these drugs will also increase the risk of fractures. Okay, so there are two groups of agents, that is option A as well as option C, which has increased risk of fractures. Yes, the canagliflozin also has other adverse effects like increased risk of urinary infections, genital mycotic infections, hypotension, but again fracture risk is also there. Now, since the question specifically asks bone fracture in females, I am having a tendency to select rosiglitazone over canagliflozin. I know that this is controversial because at least some of them would have a viewpoint of canagliflozin, but look at the simple logic here. Both the standard references have made a specific mention on female, and all my students who gave the exam also said in the question they specifically mentioned females. In that context, I think rosiglitazone is a better answer for this question. Okay. At the same time, let me also tell you, canagliflozin can also increase the risk of fracture. Okay. All right. Coming to the next question. So next question is N-acetyl P-benzoquinoamine causes hepatic necrosis in poisoning with. So I am sure many of you know this by another short form, which is the NAPQI. Okay. So this causes hepatic necrosis in paracetamol poisoning. Paracetamol poisoning. So let me throw some light into this. See, when you take paracetamol in routine therapeutic doses, 90% of the acetaminophen is metabolized in the liver. Okay, and this is metabolized in the liver to sulfate and glucuronide conjugates. Okay, so 90% is metabolized in the liver to sulfate and glucuronide conjugates, sulfate and glucuronide conjugates, and then is excreted in urine. So what about the remaining 10%? 5% is excreted unchanged in urine, whereas the remaining 5% is metabolized by the hepatic cytochrome P450 into NAPQ. Okay, this NAPQ is actually hepatotoxic, so I'm just giving it a red highlight. However, your body has protective mechanism because this NAPQ is conjugated to the hepatic glutathione. This is conjugated to the hepatic glutathione. Okay, and that results in non-toxic products and then is excreted in urine. But what happens is when you take paracetamol in toxic doses, the sulfate and glucuronide conjugation pathways are saturated. There is an increased fraction being metabolized by the hepatic cytochrome P450, and once the body's protective mechanism, that is the glutathione resources, are also depleted, that can result in accumulation of NAPQ, and accumulation of NAPQ can result in oxidative hepatic injury. It can result in oxidative hepatic injury. Okay, so answer is option A. Next question, Kasowitz phenomenon is associated with, again a factual question, answer is congenital syphilis. So what is this phenomenon? It's a simple one. See, if a patient or a woman with untreated syphilis, suppose she has a series of pregnancy, the likelihood of infection in the fetus in the later pregnancy becomes lesser and lesser. Let me clarify it more. See, in successive pregnancies, suppose initially in the first pregnancy she might have a miscarriage at the 4th month. At the next birth it improves, it might be a stillbirth at the 8th month, and in the next pregnancy you might have the child being born, the birth of an infant with congenital syphilis who goes on to die within a few weeks. Subsequently, you might have the female giving birth to an infant with a congenital syphilis who actually survives, and finally you might have the same female giving rise to healthy children. So this improvement, so-called improvement, is called a Kasowitz phenomenon. Okay, Kasowitz phenomenon in congenital syphilis. Next question, a patient presented with a painful rash as shown in image since the past 2 days. What is the diagnosis? Is it varicella zoster, herpes zoster, molluscum contagiosum, or herpes simplex? See, the distribution of rash in this picture is very characteristic, and the rash is definitely in a dermatomal distribution. That is the catch point here. It is in a dermatomal distribution. So herpes zoster is one condition which presents with a unilateral painful vesicular eruption with a definite dermatomal distribution, which may be associated with a acute neuritis. And commonly the dermatomes that are affected are the thoracic and lumbar dermatomes. And often as a complication you may get post-herpetic neuralgia as well. So this definite dermatomal distribution is pointing to herpes zoster. Molluscum contagiosum will mostly have say flesh colored papules which are umbilicated. Okay, so molluscum contagiosum will have flesh colored umbilicated papules. Okay, umbilicated papules. And chickenpox, varicella, they will have maculopapules, vesicles or scales in different stages of evolution, which appear on the trunk and face and rapidly spread to other part of the body. These lesions will definitely have an erythematous base, but definitely this does not go in a dermatomal distribution. Okay. And what about herpes simplex? See, herpes simplex again can have varied cutaneous manifestations ranging from a herpetic whitlow. Okay, you can have a herpetic whitlow. You can have a erythema multiforme. You can have a eczema herpetiticum. You can have a herpes gladiatorum. So lots of skin lesions are possible, but none of them will have a definite dermatomal distribution. Okay, so here the answer is going to be herpes zoster. Coming to the next question, very interesting, very good question. A patient presented with sudden onset painless loss of vision in the right eye. I have taken this question because this is not a pure ophthalm question, this is a neuro-ophthalmology question. So RAPD, that is the relative afferent pupillary defect, is present in the right eye. So you've got a RAPD in the right eye. Rest of the ocular examination is normal. Which of the following tests are important in the diagnostic workup? Is it MRI brain and orbit with contrast, anti-NMO and MOG antibody, blood glucose, RFT, LFT, thyroid function test? Sudden onset, okay? Remember this, sudden onset. Painless loss of vision in the right eye, RAPD. So RAPD tells you what? The problem is where? It is in the optic nerve. So you know that by now we are dealing with a case of optic neuropathy. Okay, but remember, rest of the ocular examination, all these eye movement, everything is normal. So when you have an optic neuropathy, there are different etiologies that you would consider. Say for example, one of them will be a demyelinating optic neuritis. You can have an anterior or say anterior ischemic optic neuropathy, which can be arthritic or non-arthritic. You can have a compressive optic neuropathy. Compressive optic neuropathy. So compressive optic neuropathy can occur when there is a thyroid disorder. And then an infiltrative optic neuropathy. Infiltrative optic neuropathy. So infiltrative optic neuropathy can occur in the context of autoimmune diseases, tumors. Now in this setting, first thing that you have got to consider is that of a demyelinating disorder. Why? Because see, to have an anterior ischemic optic neuropathy, they have not mentioned regarding any vascular risk factors. It is possible, okay, it is very well possible, but they have not made a definite mention on any features of non-arthritic or even arthritic. None of the giant cell arthritis features are also there. Compressive optic neuropathy, as in thyroid disorders, see, that will cause a gradual loss of vision, number one. And if it was a thyroid disorder, it's not just going to affect the optic nerve, there will be some or the other limitation in the extraocular movements as well. But the question specifically says rest of the ocular examination normal. So sudden onset with rest of the ocular examination is less likely to be any thyroid disorder. So I am more in favor of optic neuritis, which is a demyelinating optic neuritis. And demyelinating optic neuritis can occur either as a part of the prototype demyelinating disorder. What is the prototype demyelinating disorder, yes, your multiple sclerosis. It can also be a part of NMOSD, which is your neuromyelitis optica spectrum disorders, which can either be an anti-aquaporin 4, okay, anti-aquaporin 4, or it can be anti-MOG, okay, anti-MOG. So coming to the options, see, the first option, MRI brain and orbit with contrast, definitely you have got to take, because in all these demyelinating disorders you are going to see lesions, okay, you may see the lesions, typical lesions of MS, typical lesions of NMOSD. I have taught all this in my lectures, so that can be seen. So definitely MRI is a must. Anti-NMO and anti-MOG antibody, very, very important. So you have got to test NMO as well as MOG antibody, because they form a part of the NMOSD workup. Blood glucose, LFT, RFT, yes, this is also important. Why? Because in majority of these scenarios, when the patient presents with a sudden onset painless loss of vision because of a demyelinating optic neuritis, you will give the patient initially steroids, okay. Initially you will give the patient steroids, and then depending on whether it is NMO spectrum disorder, you will have to give other immunosuppressive agent as well, or is it MS. So for giving those drugs like steroids and also other immunosuppressants, you've got to have a good idea on the blood glucose, LFT, RFT. But thyroid function, see, directly it is not very important in the diagnostic workup, especially when the other features like sudden onset and rest of the ocular examination is given. So for me, the answer is going to be 1, 2 and 3. Now, many students message me, sir, is it 1 only or 1 and 2 only? They have heard from different sources. Believe me, you have got to pick this as the right answer, because this is not a ophthalmology pure question. This is a neuro-ophthalm question. So this is a part of the evaluation of an optic neuritis, and so this is going to be the best answer, 1, 2 and 3 and not option 4, because of the reasons that I have told you. Coming to the last question, again a neuro-ophthalmology question, action of the superior oblique, a very, very simple question. So you see this table on the actions of the various extraocular muscle. So any entrance exam, among the extraocular muscles, one of their favorite is the superior oblique. So their actions are going to be intorsion, depression and abduction, okay. So intorsion, depression and abduction, option D is the answer, okay, option D is the answer. So thereby we have discussed around 40 questions of the general medicine that were asked in the May INI CET 2022 exam. And as I told you, the pattern of questions this time was slightly different, slightly more in the easy to moderate, with a bit more of factual than the routine paper. However, students who have studied the concepts well, they have practiced enough exams, they have done well. Let me tell all of you, just go through these question areas and identify which are the key areas important, and you can definitely message me for any doubts for any of the questions, and also during your preparation I shall always be there to help you. So I'll just share my WhatsApp and Telegram number. This is my WhatsApp and Telegram number, okay. So any doubt you have in your preparation, I have a Telegram group as well as the Facebook page in the name of Dr. Rahul Rajeev. Also there is I have Facebook groups, that is the medicine for Neet PG and INI CET and FMG. There is a specific group also. So you can stay in touch, ask me any doubts, and if you want to have any advice from my side for your preparation, I shall be more than happy to help you. All right. Okay. Hope you found this session very useful. Thank you.